Welcome to our first Health and Focus panel. I am so excited to be bringing together two very different but equally powerful voices in the conversation around endometriosis, something that I know has been discussed at length in politics and in government and in the media. One is a public advocate whose honesty has really helped shape the conversation around endometriosis and make it visible. Julie Snook, Ambassador for Endometriosis Australia. And the other is someone that we know has been on Health and Focus before. She's a medical and policy leader working to transform how our health system recognises and treats women's pain. Dr. Ramya Raman, Vice President of the RICGP. Welcome both. I am so delighted to have you here.
Thank you for having us on, Catherine. Nice to see you again.
Thank you for having us. It's so lovely to be here.
So my first question is for both of you, but I might start with Julie first. Endometriosis is one of the most common diseases amongst women, yet for some reason we are still calling it underdiagnosed and misunderstood, underfunded. Like, it's a conversation that we've been having for so many years, but it seems like we're not really getting anywhere. Do you think that this is a failure of science or the health system or society or something else?
Well, that's a really good question to start with. Look, I was diagnosed with this condition over 20 years ago. And when I think back 20 years, I do feel we've come a long way, but then I realize it's been more than 2 decades. And to me, in this role as an ambassador for Endometriosis Australia, I've really only been speaking about it on a public platform for probably the past 5 years. So for me, while we have come a long way in terms of the media coverage, in terms of the funding and the government support and the general conversation around this condition, there is still so much more that needs to be done. Earlier in the year, I went to the World Congress for Endometriosis here in Sydney, and I was really, really buoyed by the research in this space, by the phenomenal medical minds worldwide who are dedicating their careers to this condition. It also made me feel a little less crazy, which is a term we use a lot as patients of endo, because you start to question whether or not you do actually have it and whether or not this is in your mind. But to speak to these people, to sit down and have these conversations with doctors and researchers and scientists from right across the world, they haven't just been researching this for 5 years. They've been spending their entire medical careers dedicated to this condition. So we have come a long way in what perhaps feels like a short amount of time to those listening at home and those that are hearing about this condition a lot more in the mainstream media. But we have so much more work to do. And I think it's a collective. It's at the government level. It's at the medical level. It's even in our workplaces. And it's up to us as individuals, as the medical minds, as well as us as patient advocates, to be out there having these conversations and having the difficult conversations as well, and not shying away from the nitty-gritty surrounding this condition.
Ramya, I'm interested in your insights, obviously as one of the medical practitioners that is on the other end trying to champion some of this. What do you think is, I guess, the barrier to us having, I guess, a bit of understanding of endometriosis and then also, I guess, better treatments for it?
Yes, certainly. Julie, thank you for sharing your perspective. I think it's really important to hear it from a patient-centered approach, particularly someone who's been through that journey and experienced it. It's actually really powerful. And I say that because I'm a practicing GP and I do look after a lot of women for women's healthcare. And it's actually got to be really focused on the patient. So I think, coming back to the question, it's a combination of all three. So do we call it underdiagnosed? Is it misunderstood? Or is it underfunded? All three components actually weave into that. But if I had to specifically from my clinical practice and my experience of managing and looking after patients, I'd probably have to choose to say that it would be systemic as well as societal factors that contribute towards that. For many years and for a long time, many of my patients have said to me, Ramya, women's pain has been minimised and perhaps even normalised. And there are cultural differences in where women are coming from as well. And it has sort of become, it's part of being a woman the cultural conditioning and the filters that run into how we even design research, allocate our funding, and even teaching the next generation of doctors. Now, it's not all doom and gloom. These are the factors which have been identified and which is really quite real in a person's life. And I think from a general practice lens, we are making those changes, the awareness, both patient awareness as well as medical practitioner awareness. And I teach medical students, supervising them in clinical practice as well as teaching them in university. And this has really become more and more integrated into the curriculum for general practice as well as medical students, which I think is really positive. And it's actually come from patient advocacy and the truth of healthcare, which should be patient-centered.
And Julie, you mentioned that you were diagnosed quite a while ago, but really this has only been a topic that you've kind of been actively involved in the last 5 years, because I guess that's when people started talking about it. Why has there been that gap in terms of, like, we've known endometriosis has been around a long time, but why are we only now just, I guess, starting to talk about it?
Again, that's a great question, and I don't know if I have the answer to that. When I was diagnosed 20 years ago, I was living in regional New South Wales, just for a little bit of context. And I think I'd been presenting to doctors with my symptoms for the average that we see about 6 years, basically since I was sort of that 13 years of age. And I kept presenting with all of these symptoms and no one knew what it was. And I kept going back for tests, and it ended up being, I was about 18 and I almost begged my GP, please, can I have a referral to go and see a gynecologist? I think this is the best way forward for me. And that was really me having to go and advise for myself. And I went in, and that's when the doctor, within minutes of reading my wad of files, said to me, I think it's endometriosis, but of course we won't know until we operate. So that was the start of it for me. I didn't know what the word was. I'd never heard of it. No one in my family was really talking about it. It turns out there is a long family history of this condition. So it was this culmination, this perfect storm almost, that for such a long time, no one knew anything about this. I don't know. I can't obviously speak from medical space, but from my side of things, I just kept going and saying, is there something else I can try? Or are there other ways around this? And it was also the attitude towards me as a patient. Doctors saying, go and have a baby. You'll be fine. Go and have a baby. Fix it. Well, I'm 20. I'm 20. I'm a journalist, a cadet journalist. I'm starting out in my career. I'm also single and I don't really want to have a baby now. So what are the other options? So there has been a huge shift in the mentality surrounding this condition, I would say, within the medical space, as well as us as patients. Perhaps we found our voice. Perhaps the reason I started talking about it was because I got fed up, to be fair. I got sick of hiding it. I got sick of going to work, really sick, and not being able to explain it and not feeling like I was being believed or supported in the workplace. So I think there are just so many factors to this that has built this perfect storm over time. But now the good thing is we have this attention, we have the research, we have the funding, and we have wonderful minds that are working really, really hard to ensure that the next generation of women don't have to go through, such a long period of time before diagnosis, and perhaps they won't need to go through the invasive ways in which we do need that diagnosis and those treatments.
Ramya, that delay that Julie's talking about, that's sort of somewhere between 6 and 10 years, and I guess the fact as well that the only way to really find out if someone has endometriosis is to have surgery, which is in itself a big barrier. What, if you were to kind of look at all of the different options for patients, what's kind of the one thing that we could do to try and close that gap so it doesn't take 6 to 10 years for someone to be diagnosed?
Yeah, certainly. And it's one of the most addressable barriers, I think, is what we're talking about. And one of the most addressable barriers from my point of view as a GP is early recognition at the first point of care. So that is with your GP or your trusted doctor. And Julie, I hear what you have gone through, and I guess the challenge that it took that period of time. And I really thank you for the work and the continuing work that you're doing in this space, because it's actually really important to bring that voice of the patient and keep it patient-centered and remind us that medicine is a science, but there's also an art and a story that goes with the consultation. And it's the patient story that drives the outcomes for the patient, which is never going to be the same for everyone else. So I think one of the key addressable barriers is actually early recognition at the point of care. And that's not necessarily surgery. First and foremost, in medical school, I'm just reminded the first thing that we are taught is when the patient starts talking, don't say anything for the first 90 seconds. Allow the patient to talk. The power of listening. The question is, do we all do it in health space? And I think there are a lot of challenges in that space. Perhaps we're not doing it as much. But there is a lot of scope for improvement, and GPs are the first point of contact where patients often talk about period pain, fertility, infertility, subfertility, fatigue, pelvic pain. So the need for the time, training, and the continuity will help to enable those dots. And it's about opening up that conversation. And I often tell patients, if you've got concerns and you're worried about something, just bring it to the table, because what it actually means is that you can have a really open conversation about all the differentials. I think as a clinician, one of the challenges that we all face is the balance between ensuring we are listening to the patient, but also validating what the patient is experiencing, balancing that with the evidence of the differentials that we need to be considering. It's no excuse by any means. There are gaps. And certainly I think with endometriosis, the access to diagnostic imaging, surgical expertise, and the access to multidisciplinary pain care management, and that would involve, non-GP specialists, physiotherapists, the access to that, particularly for our patients living in rural and remote areas of Australia. And I live in the largest state in Australia, in WA, and I know that access is one of the key components of it. And I think it's bringing all of those together.
Julie, I can imagine it's such a long and lonely road to being believed, and you've spoken about your journey, and particularly being in a rural community as well, the challenges with getting access. At what point along your journey did you come across someone like Ramya, who was very much about listening to the patient and hearing what you were kind of going through and how you can plan the next steps together?
It took about a decade.
Wow.
It took about a decade. I left regional New South Wales when I was 21 and pursued my career. And I went to Canberra, where I had a wonderful surgeon who was, I adored him, but at the same time, his mentality was a little bit more, what I would say, archaic. He was not really thinking in a progressive manner to what suited me at that stage in my life. While he was a brilliant doctor and surgeon, he wasn't progressive in what we're seeing now. When I came here to Sydney about 12, 13 years ago, I went to my GP and she recommended a surgeon who is just, he's still my surgeon now. I adore him. I've sent so many people to him. And it's so interesting that you say that, 90 seconds. I think the first person that pops into my mind is my surgeon, and he sits and he listens. And that is when everything comes out, when we're given that moment to just say, oh, this is the situation. It's so refreshing because it feels like you are being heard. And that's really important in this process, to be heard, because a lot of the way it is, as you said, it's quite lonely and you're masking a lot to just forge ahead and get on with your life. So my surgeon here in Sydney, about 12 or 13 years ago, I met him, and he was the first that really just said, it's okay. This is how we will approach it. And this is, a great path forward for you. And he introduced me to a whole other world that I didn't really know existed. I changed my diet. I went to pelvic pain specialist, physiotherapy, these wonderful services, again, that we're very privileged to have in cities like Sydney and Perth and whatnot. But when you're in the regional centres, it's just so hard to access. And I think also in that last decade, the information has become so much more accessible at our own fingertips. Like anything, it's a blessing and a curse, the internet. But all of a sudden we can read about different experiences. We can learn about different diets. I think diet is such a huge part of this condition. Well, it has been to me. So just having that one person to set you on the right course is life-changing at the end of the day. And he has been incredible. I was so hopeful that he would deliver my baby, but he let go of obstetrics and went down the path of gynecology and focusing in on this area and focusing on the surgical technology and focusing on the less invasive way of treating this condition. So he now dedicates his time to it, which is amazing because he is so good. But it takes that one doctor to hear you, even if it is in that first 90 seconds, and that can change your life.
I'm glad your story has, I guess, it's obviously been challenging with lots of sort of windy roads, but I'm glad that there's someone that's kind of come along and been a bit of a beacon of light for you and I guess made it just that little bit easier, which is something that I know, not all patients have. And as you said, like if you're in a rural community, you don't have access to all of that wraparound stuff. Like it's the diet, it's the advice, it's the pain clinics. Like it's not necessarily just surgery as kind of your one single only option for treatment.
And let's remember the financial ramification of this condition as well. When I was diagnosed, I was a cadet journalist, and hot tip, I wasn't paid much. A real struggle to try and pay for all of this stuff, and it still is. I'm fortunate to be married and have a great job and a beautiful home, but it's very expensive, and not everyone can afford all of this extra support. So to be in a position that I am now, I'm very lucky. I always say that I'm one of the lucky ones. It's not that case for everyone, but I was really moved a couple of years ago. I was asked to one of the universities here in Sydney to speak to student doctors who were in training, and they wanted to hear from the patients their experience. And they were asking the question, how can we help you moving forward in our studies as GPs, as surgeons, whatever path they went down? They wanted to know from their perspective what they could be doing to make this a better experience for the patient. And I thought that was an incredible incentive by the university. I thought it was wonderful to see these students just asking the tough questions and being really open to hearing what we as patients would like to experience and how it would make our journey that little bit easier. So I think that's really positive. I think we're really heading down a positive path.
Ramya, you are such a fierce advocate for compassion and credibility when it comes to women's health. When you hear advocates like Julie speak so powerfully from lived experience, what do you learn, but also what challenges does this create for doctors who are ultimately trying to treat very, very complex diseases that have, multiple different touch points within what is often quite a constrained health system?
Sure. Thank you. And if you don't mind, I just wanted to add something else, as I often digress in the conversation. So, Julie, as you were just speaking, a couple of things came to my mind, and I thought it would be nice to sort of share that as well. And I think you've really touched on an important concept of what Catherine had asked earlier on about what matters most. And I had responded with system design. So system design and delivery does make a huge difference. When consultations are quite rushed or fragmented, subtle but important patterns actually get missed. And I'd say that responsibility actually lies across the spectrum, all the way through from what you had explained as education in medical schools, like opportunities to include that within the curriculum, through to funding models that allow for longer consultations, which is a key priority for us in general practice, especially for female GPs. In consultation, we know how much it can have an impact for our patients. And your story is a really, and it's the exact 90-second rule, but of course, a little bit more than 90 seconds would be great. And the third thing is health policies that really help to prioritize the early diagnosis pathways. And I think one of the really fortunate things that we have had is we are actually in a really good health system where primary care is the front and center of our healthcare system. And recently, the federal government has funded endometriosis clinics to be embedded within general practices throughout Australia. And it actually improves access, but also it brings together the multidisciplinary team care approach that makes it more the wraparound care, I guess, for the patient. It's much more it's not about focusing on the condition, but instead focusing on the patient, which, is a key priority there. So I was in Fiji earlier this year for a professional conference with the College of GPs there. And I have presented in the conference regarding endometriosis and endometriosis management from a general practice perspective here in Australia. And the feedback that I received from colleagues in Fiji who are practicing as GPs are, we really need that system support here to enable that care for our women, which we are missing. And so that, I felt that we are certainly, multi-steps forward here in Australia in relation to getting that support, but we've got more work to do. And I think, from a global perspective, there's a lot of cultural differences in the way that women actually experience pain, and perhaps a lack of acknowledgement about that pain being abnormal is a consideration to have. And I just thought I'll sort of share some of those reflections from some of my experiences this year as well. And Catherine, you may need to repeat that question again.
No, you actually kind of answered it, because I guess where you were sort of talking, like in terms of those the limits that we have, it is that longer conversation, the time to be able to have that longer conversation with the patient to unpack some of this, but also that multidisciplinary team care. Like Julie was talking about how diet is really important in her sort of prognosis and treatment. And so I guess, is it that we need to be having multidisciplinary teams when we're looking at endometriosis, and is it having a dietitian and maybe a physiotherapist? Like, what are the different groups that we need to be wrapping around the patient in that kind of primary health space? I don't know, Julie, if you've got sort of any reflections from your own journey of where that, I guess, those longer conversations in that time, but also that multidisciplinary team care was really important for you.
Yeah, I found it to be quite educational. And again, I didn't realize that these services were available. And we're very fortunate here in Sydney to have a clinic where you can go from your gynecologist, you can go straight in to see the pelvic pain specialist, you can have a conversation with a dietitian, there's acupuncture available. This is a whole clinic in the CBD where it is designed to, I say, wrap their arms around you. Because it's a big hug. It feels like you're just getting, there are so many more options. But something really, and I'm very, very passionate about, is also the mental health toll that this takes on patients. And I think that is something that we need to be considering and perhaps, investing in as well, is that mental health support. Because a lot of people that I speak to who have this condition, and again, I've had my own experiences, the mental toll that this takes, especially as a young woman, you're trying to navigate life the best you can and your body is telling you otherwise. And then you get into that stage of fertility, and that becomes a whole other challenge for many people. And it's just this cycle that continues on. It doesn't disappear. And when you're talking about year on year on year, that is very damaging and very dangerous for some individuals. And I think it's really important that we take it seriously, the mental health toll that this takes. And not everyone's brave enough, not everyone has the ability like me to sit out here in the public domain and have a chat about my condition and my experiences. So I think it's really important that we take it seriously, all elements of it. And it's so lovely and wonderful to hear that GPs, and I've even noticed it, I've got a new GP, we moved to the area, and same thing, she took that time. And I think sometimes maybe that's all we need. We just need that little bit of extra time to know that we're okay and that we're supported. So I think it's very holistic. There is a lot to this condition. It is not just one part that makes it better. It's a very vague response, I appreciate, but I just think in my experience, there is a lot to it. And if there are ways that people can access and a variety of specialists and support services, that again, it can be life-changing.
Now, we do have to sort of wrap it up because we are coming to time, but I do have one last question to ask you both. When it comes to endometriosis, I feel like we talk a lot about raising awareness. It's all about the awareness. But I feel like there's a point where we kind of need to move beyond the awareness and actually into taking some action. If there was one sort of change that you could make, whether it was like regulation or something in the system? It could be big, it could be small. What would you do to actually start moving us more into an actionable kind of space? I might start with you, Ramya.
Sure. No worries. I think from a general practice and a primary care perspective, ensuring that there is an ability for patients to see their GP for longer consultations and have better patient Medicare rebates for longer consultations is actually really important. All the discussions that we have had here, and to an extent, it's not limited just to endometriosis. There are multiple other conditions in women's health and other chronic conditions that have a similar theme, and it's about trying to ensure that to have a patient-centered care and an approach, we do need to have that time. We already give that time. We just want to be able to see that the patient receives a better patient Medicare rebate for the time that we are spending with them. And that should be across the country, no matter what postcode. And so that's an enabling factor. The second component to this would be enhancing multidisciplinary team approach within general practice. I'm in a practice where I look after a lot of women for women's health as well as other conditions. I have a physio, a dietitian, a podiatrist, and access to a psychologist. All of my colleagues who work with me, and if there is considerations for a woman for managing pelvic pain or endometrial pain, subfertility, infertility, all of my colleagues are involved in their care. And one of the best feedback that I receive, and a lot of my reception staff and my practice manager receives, is we're just really glad we can just come to the one place to have all this. And we know that because, the GP, so, I've initiated the referral, we're all talking to each other. So there is a shared understanding about the patient outcomes as well. So I guess in summary, enabling better, longer consultation and patient Medicare rebates for the patient, and for better patient outcomes, enabling structures and funding models to support multidisciplinary team care approach within general practice, which is occurring in a lot of practices already, but making it much more streamlined and enabling that model will just mean that it can be scalable.
And I guess also making it, like you said, like it shouldn't be based on postcode, and it's so important. Like, it's not, as Julie sort of said, it's not just about endometriosis. There's all the other things. It's mental health. There could be infertility. Like, there are so many different things. Let's look at it as that kind of holistic patient and then make it so it's like a one-stop shop, I guess. Julie, any kind of reflections from you on, I guess, the one thing that you would like to see?
I won't be nearly as eloquent as my response. It's very hard. I wish there was just one thing, but I do feel like there could be, a bit of a two-pronged approach here, I suppose. And I don't want to sound ungrateful, because here in Australia, we are really leading the way in terms of research and funding for this condition. But I think funding is where it starts, so that we have these incredible medical minds that can go out there and do what they want to be doing and treat the patients the way they want to be treated. So funding is one thing. And look, the federal government and, the Ainsworth family and those sort of individuals are really putting their money where their mouth is, and they're showing that support to this condition and others, chronic conditions impacting women in Australia as well. But then I suppose it is also down to our medical minds, our doctors, our GPs are the first port of call, and we want them to be allocating that time. We want them to be able to have that time to allocate. It's already a system that's so much pressure. It's so hard to get into doctors in regional New South Wales. So for me, my passion, my priority, it's where I've come from, the regions, a country town. They need to have access to doctors. It's a basic human right that they should be given here in Australia. So if there was a way that we can be getting these doctors to regional centres more frequently, even if it is in a fly-in fly-out situation, that would be something that I would love to see, because in the cities, we're so lucky. In the countries, it's much, much harder to access the support that you need.
Yeah, look, great suggestions. For those of you tuning in, endometriosis is obviously a disease that affects so many people. I'd love for you to leave us a comment, share your thoughts and your story. We'd be really grateful. Ramya, Julie, thank you so much for joining me, being so honest and forthcoming. I hope we can have this conversation again soon.
Thank you.
Thank you.
Hey, if you like that episode, we'd love for you to share it on social media. It really helps get the show out to more people.
And if you want to support the show, consider becoming an Emplio Plus member to unlock bonus content and exclusive insights delivered straight to your inbox.
Thanks for watching and supporting the future of independent media.